Pulmonary edema. Brief description. Principles of management and follow-up is similar but more frequent than other acute heart failure (AHF) syndromes. Early oxygenation and ventilation support is life-saving. Treatable precipitating causes, e.g., arrhythmia, hypertensive crisis, acute coronary syndrome (ACS), should be looked for and managed promptly. Clinical features. Rapid development of dyspnea at rest, cardiorespiratory distress, tachypnea, oxygen saturation, SO2, less than 90%, high/normal blood pressure, BP, crepitations and wheeze in the lung, raised jugular venous pressure, JVP, S3 gallop, treatable causes of pulmonary edema, e.g., hypertensive emergency, acute coronary syndrome, ACS, arrhythmia like atrial fibrillation, AF, should be seriously looked for and managed according to the respective protocol together with management of pulmonary edema. Treatment. Non-pharmacologic. Oxygenation. Sitting position. If oxygen saturation, SO2, less than 90%, administer oxygen O2 by nasal cannula at 4 to 6 liters per minute, L per minute. If SO2 doesn't improve in 10 minutes, min, administer high-flow O2, 10 to 12 L per minute by face mask. If SO2 is still low, give ventilator support by continuous positive airway pressure, CPAP, in conscious cooperative patients, or intubate if patient cannot protect his/her airways, and put on mechanical ventilation, MV, with low positive end expiratory pressure, PEEP. If SO2 is persistently higher than 90% and cardiorespiratory distress improves with treatment, revert O2 administration to nasal cannula and progressively decrease O2 flow and discontinue. Pharmacologic. Administer morphine 2 to 4 mg intravenous IV bolus every 2 to 4 hours HR. Furosemide 40 mg IV for naive intravenous dose which is equal to their previous oral dose for those already taking oral furosemide, and double the dose every 1 hour until adequate urine output and crackles in the chest start to decrease, and maintain the dose of furosemide that gave adequate response every 4 hours for the first 24 hours and decrease frequency in subsequent days. Follow-up of response and other management principles are similar to management of other acute heart failure syndromes. For patients not responding adequately to diuretics with systolic BP greater than 110 mmHg millimeters of mercury, the following vasodilator therapies can be used. Intravenous nitroglycerin infusion started with 10 to 20 micrograms mg per minute and escalated to 200 mg per minute depending on response and development of hypertension can be used. If nitroglycerin not available, either of the following can be tried. Isosorbide dinitrate 10 mg per os, PO 3 times a day, TID, 8 a.m., 1 p.m. and 6 p.m., escalated to 40 mg PO TID. Or captopril 12.5 mg or enalapril 2.5 mg, an increased dose every 6 hours depending on response. Thanks for watching. If you found this video helpful, feel free to give it a like and share it with someone who might benefit. Don't forget to subscribe and turn on notifications so you won't miss future uploads. If you have questions or want to see a specific topic next, drop a comment below. I'd love to hear from you. See you in the next video.